All right, guys. So, like I said, thanks for showing up and everything. So, what we're going to do is go ahead and get started on this. So, like I said, it's pretty short, not a whole lot to it. Basically, we'll just be covering like everything that you guys covered this week. So, only 4 lectures. I do have like the stars and stuff like usual. And that's the stuff especially if there's like more than like 1 or 2 stars, then I like really remember there being a question on it or something related to that anyway. Um, But like occasionally, I'll put a star if I find it um, either important now or later or whatever. So either way, we'll go ahead and get started. And if anybody has any questions along the way, just let me know. So just start off the first one. So DNA and antimetabolites. I always leave these in here just in case, like, because I think we had a couple of lectures, I think last year toward the end, where she like had this drugs to know for now thing, but she didn't actually like put it in red or anything, so I was confused. So I just kind of left them in here, like I did the last review, just in case she forgot to read one of them or something. I left this slide here. It doesn't have any red to it, but I've had like at least a few like board practice questions ask this deal. And she does kind of like mention it, but I feel like it's just like easier to kind of see it on this slide. So quinolones and fluoroquinolones, which we'll talk about here in a second, their main path here is to inhibit DNA gyrase, which is just another name for topoisomerase 2 and technically topoisomerase 4, but you never hear about that. You always hear about the DNA gyrase. And that's what I've had on my practice questions when I've had like on boards type practice questions. It would just be like, I'd give you a situation where you'd prescribe one, and then it would ask you like what the mechanism is. So it's kind of similar to how they ask stuff on the exam, but it's just to give you an insight on that might be important later on, but not maybe not necessarily here, but later. All right, so then fluoroquinolones, right? So this chart's like really important to know, only because you have to realize like which fluoroquinolone is like covering what. That's super important. This top one's not really all that important at all, and she doesn't have it in bold or anything. Honestly, we never got a question about it or anything, so I wouldn't worry about the top one. But definitely Cipro, Levo, and Moxie. And the things you need to kind of do here is you need to realize that these are respiratory fluoroquinolones, so Levo and Moxie. So L and M, they're used more for like pneumonia type stuff. So of course they're going to cover, and on top of that, they have some Pseudomonas coverage as well, but they all kind of do, if you notice, right? But for the most part, since they're respiratory fluoroquinolones, they're going to cover pneumonia. And so you can see she lists off all these different pneumonia bacteria. But of course, like the more common one you're going to hear about is like strep pneumo. I mean, that's like the big one, right? So, and then you have Cipro. Okay, so that one's going to cover um, more so just gram-negative aerobes. So notice that these that lists anaerobes on this one, right? So Moxie is more like maybe some anaerobes, but Cipro is way more like aerobes specifically. Um, so just kind of keep that in mind in terms of like differentiating the two. The big differentiation by far is just knowing that Levo and Moxie are respiratory fluoroquinolones, so you would give that for pneumonia type infections, and that Cipro you would not. Um, but basically, like gram-negative bacteria for the most part on Cipro. All right, general use of fluoroquinolones. Honestly, so this kind of like goes with that last slide. I kind of covered most of this anyway. I put this in bold when I was, back in that class anyway, just because it like covers specifically bacteriorities, just because I thought it might be kind of important. I don't remember there being a question specifically on that bacteria, but I definitely do remember getting questions along the lines of like this person comes in with pneumonia, which drug would you prescribe? And of course, they're going to give you like either Levo or Moxie as an answer, and then they would give you Cipro to try to trick you. So just make sure to know the differences. And then this kind of, like I said, it kind of goes into it anyway. How it says inhibition of topoisomerase, we kind of covered that with the DNA gyrase thing. And it leads to cleavage of DNA and cell death. So she wants you to specifically know that. portion. I guess she doesn't care as much to know about the topoisomerase, but I would still probably kind of put that in your memory just in case. Um, but yeah, so cleavage, DNA, and cell death. Resistance. So there is some like cross resistance among fluoroquinolones. So that basically just means, if you have resistance in one of the fluoroquinolones, then you might have, resistance elsewhere. And that's pretty much it in terms of action and resistance that she wanted you to know. Now on to kinetics. So the thing I remember a lot about, and we'll get into this here in a second because the adverse effects are really important for these drugs. And it mentions it just a little bit here about the chelation thing here. But anyway, so kinetics, okay. So in order to achieve, so they achieve high levels in most compartments except the CNS. So that just means that they're not able to cross that blood-brain barrier very easily. And then moxie specifically is limited to limited in urinary concentrations. And then this chelation thing, like I said, it'll come back, and that's kind of one of its adverse effects. And of course, with that chelation, it kind of limits absorption because it kind of like blocks those receptors and those channels, right? So that way, it's just harder for absorption to take place because all that metal ion type stuff is just in the way. All right, so now adverse effects. So this slide was really important, definitely to know. So I would keep this one in your mind because she tends to like to ask about like mechanism of action's a big one on her, and she likes to ask adverse effects a lot. So those are always important as well as just in general what would you prescribe. She does have those questions, but she does like to ask adverse effects a lot. Specifically the ones that are like big hitters from what I remember. Definitely the photosensitivity you would need to know. Honestly, everything in red is pretty high yield for sure. But the photosensitivity, I think there might have been a question related to that. But we'll talk about that later anyway, because there's like a little way to kind of remember that she covers. Um, but yeah, so just make sure that you just know everything in red here. That it's got that chelation issue that we already talked about. That photosensitivity, so you'll have somebody that's like basically kind of like a sunburnt look to them after they've taken this like particular drug, right? And that they're like basically hypersensitive to the sun, right? So that's just something to kind of keep in mind. And then QTC prolongation, so that just means just prolongation of that particular sequence of the rhythm, I guess you would say. But and then tendinitis, that's also important to know with not tetracycline, fluoroquinolones. Yeah, that's a pretty specific to fluoroquinolones. But yeah, so make sure you just know everything in red. And then mechanisms. So I just left this slide here to kind of give like a little bit of a like transition to the next ones. And also, it's like I think I might have had like practice questions related to these like board wise, so I just kept them in here just in case. Anyway, this inhibits. So notice sulfonamides, right, and sulfones. They inhibit dihydrooctanoate, or however you say that, synthase. While TMP and pyrimethamine, okay, they inhibit DHFR basically, or dihydrofolate reductase. But like I said, I don't think she'll ask you that because it's not in red, but I have had like practice questions or something like that on that. Folate antagonists, so that's the ones. So now we're talking about these specific drugs that we just mentioned, like the mechanism of action for. So sulfonamides, the more important one here to know from that category is sulfamethoxazole. Yeah, I guess that's how you say that. Sorry if I butcher some of these names. It's more than likely gonna happen. But anyway, so sulfamethoxazole. Okay, so that's like the main one she wants you to know from that category. And of course, if she mentions, of course, she'll mention the adverse effects, and so you'll have to be able to like basically match the name of the drug to the effect or to the mechanism or whatnot, right? So that's kind of the way you need to sort of approach it. And then she has, so these are your DHFR inhibitors. So these are going to be more in that category along with like TMP. And that's why you have trimethoprim, which is TMP, and then you have pyrimethamine. So we'll get back into that one later, I think, with malaria. But yeah, so just make sure you know that those are in this category as well. Then on to just the spectrum of TMP SMX. So make sure you know the coverage for sure. Pneumocystis cerevisiae, I think that's how you say it, something like that. That's more like common in like I think it's like HIV patients are the ones that get that. Don't hold me to that, but I'm pretty sure that's like that specific bacteria is like associated. It's kind of one of those opportunistic infections with HIV patients. Enterobacteriae, that's more like a gut bacteria. Then you have CA MRSA, so make sure you know that it's CA MRSA, not just regular MRSA. And then protozoa, so that's going to be more things like, you know, I know it's not Giardia, but it's something kind of in that, toward that end of the spectrum over that direction. So it's something kind of like off the wall, basically. And then, so as far as kinetics, the only thing that was important that I noted was the inacetylation with sulfonamides. So what that basically means is that it has to go and get acetylated before it's able to be eliminated fully through the urine and things like that for clearance. So it must go through this process of inacetylation. And then the reason I have the star there is because she talks about specifically Steven Johnson syndrome, um, and how like all of that stuff is related to that acetylation step, that Steven Johnson syndrome thing. Um, and then also along with that, so there's going to be cross sensitivity with other sulfonamides. So it's kind of similar in a way to those fluoroquinolones that we were talking about, how they have cross reactivity or cross sensitivity. Along with that, you do have a rash with these, and you have crystal urea. So make sure you have plenty of fluid with that, because that basically just means you have just a bunch of crystals in your urine, basically. And these, once again, it's photosensitive, so make sure you know the photosensitive thing, because there will be a question probably with someone that has like photosensitivity. They'll describe it, and then they'll ask you, like which drug, and they'll probably give you maybe a condition that they were treated for. So that may be a way to differentiate it. So basically, like, if it was treated for pneumonia, then you would want to think Levo or Moxie, of course, right? But if it comes across as like something that you would use for sulfonamides, right? Say it's something like that, then you would want to be thinking more toward sulfamethoxazole, right? So just kind of keep that in mind in terms of how they would ask stuff. Once again, just kind of already mentioned this, the Steven Johnson syndrome. I kept this slide in here because it may be important to kind of know what Steven Johnson syndrome looks like. So that way, if they did ask you a question, it would be, which drug, has the issues with the Steven Johnson syndrome patients or something like that, then that would be sulfamethoxazole probably, because that's the only one she put in red on those particular drugs. Then adverse effects of folate antagonists. So we've already talked about, some other adverse effects, but these are like even more. So hemolytic anemia and G6PD. Pretty much every time they ever mention G6PD, it seems to end up being important somehow, some way. So I always put a star near anything that ever mentions G6PD. Um, and so just make sure you realize that it's dangerous to give those patients sulfonamides or sulfones. Then TMP, so they have leukopenia, and on top of that, they have macrocytic anemia can also happen with them as well. So I don't know if she would really ask you a question pertaining to that, but like I said, G6PD tends to almost always be brought up somewhere, so I just always highlight it. And then on to, so this is rifamycins. So these are like totally different drugs. So rifampin's by far like the one you need to know. Um, Now, what's really important to know about rifampin is that it's like the main drug you would give for TB. Um, but there are other drugs that you give along with treating like active TB. But this is the one that like it's typically the go-to, like the one everyone thinks about. And so with that in mind, of course, TB is basically mycobacteria, so that's what, they're basically kind of saying the same thing. And then so resistance wise, I don't really know what she meant by this like rapid and predictable thing. Oh, never. Question. Yeah, yeah. So ripe. So R stands for rifampin. Yeah, and then we get on to isoniazide. So that's your I, and then I think we even talk about the P and E. Yeah, we talk about both of those later. But yeah, so ripe is definitely what you would see in like typical board exam prep stuff. But we do have it. I know we had it mentioned later on, like with path and stuff like that. So it'll come back up anyway. But yeah, so rifampin, big one for specifically TB. And then on to this. So another thing I thought was like super high yield on that exam was talking about like urine colors. I know we had that like quite a bit. It seemed like we had like maybe a question or two on it, but I felt like it was probably just one question. But anyway, so rifampin specifically stains bodily fluids red and orange, red slash orange, I guess. Um, and that's kind of like the more important thing in terms of on this slide because I remember it specifically being maybe one of the questions. Um, and then it's got other stuff here as well. So it's like a powerful enzyme inducer and cause like hepatitis, and then it can also cause this like flu-like hypersensitivity. But yeah, definitely remember the bodily fluids red orange thing with rifampin. All right, so then on to rifamycin. Um, so basically, so we actually just talked about these actually, like a couple of these not too long ago with our GI exam. So it's kind of funny that it came back up because we talked about, I think it was with, with traveler's diarrhea specifically actually. So make sure you know that rifamycin you would give with uncomplicated traveler's diarrhea. So that's pretty much all you need to know for this specific slide. Then you have metro or metronidazole. Okay, so the spectrum that they give for this is protozoa. So of course that includes like Giardia and Trick. And then along with that, anaerobes and H. pylori. Usually you hear a lot about it, at least like practice question wise, and even of course with GI, you hear a lot about it being used with C. diff as first line. Um, So she may like bring that back up as being, so they might give an example of someone with C. diff, um, and you have to know that you give Metro for that. Um, and also, probably wouldn't be a bad idea to just kind of put this mechanism kind of in your mind as well. She does have like the title in red, so maybe she means that you could also have a question on that. But more than likely, she's probably going to ask you. These things are in red right here. The MC diff. So adverse effects of Metro. So this is very important to know. I don't know. I don't remember them asking. Maybe they did specifically ask about disulfiram on this test because we've had a lot of tests where we've had disulfiram reaction on. But I definitely would think it's important to know. But anyway, so metronidazole. The reason that it causes this thing called disulfiram reaction. If you have chat again. I think they did ask it. Oh, okay. But say I know like it's usually pretty important to know, and I know we had it not that long ago on a couple of our exams. But yeah, I really wouldn't doubt that she would ask it on your guys' either. So that's why I actually have a slide. Metronidazole is no longer for. Oh, okay. So it's kind of like it really just depends on who you talk to on that, from what I understand. Um, so I think it just changed like a little bit in the literature or something like that. But yeah, you can either give oral vancomycin or you can give Metro. Typically, you're probably more than likely correct on that because I think she actually corrected it on ours as well. That you're typically going to give oral vancomycin or this. I wish I could remember the other one. It's something with an F. Floxamoxicin or something like that. I think that's the name of that one. So you either give oral vancomycin or you give that one. Those are technically now first line. But however, if you can't, if you don't have any access to oral vanc or the other drug that I was trying to mention, then you would possibly give metronidazole. So yeah, it probably has moved down slightly in the list. but it's definitely still important to know the association with C. diff. Does that make sense? Yeah. Yeah, and that's pretty much the same explanation, but appreciate the added comments. So I didn't remember that portion, but I definitely remembered the other stuff. But anyway, so along with this metronidazole, let me move this thing over here. I don't really need this space. So metronidazole. So if you take that with alcohol, then you can get this thing called disulfram reaction. And the reason that happens is because metronidazole can lead to, of course, the inhibition of aldehyde dehydrogenase. Like I said, it's mentioned later on in the slides. I have a slide like kept in there for it. So I'll recover that back up when we get to it. Then we have, oh goodness, natab, nitazoxanide. Yeah, I guess that's how you might say it. But anyway, that drug specifically for giardia. So they'd give you like someone that comes in with something that sounds a lot like giardia. Um, More than likely, it's going to be a child, of course, because she says specifically giardia in kids. So if you see that and it matches up with that, then you would give them this specific drug for that. All right, then on to urinary tract antiseptics. So it's like a different kind of category altogether. So you have phenazopyridine. So I put the like star over here because it has like urine color to orange or red. So I figured I'd put that over there just in case maybe it was that question asked instead. But I think we had a rifampin question, so maybe she could like reword it and put this drug instead. Another thing to know about that is that it's contraindicated in patients with creatinine clearance of less than 50. But like I said, I don't remember her really asking much about this drug in particular. So unless she's kind of like changed it over the past year, I just don't see it being as high yield as rifampin. Then nitrofurantoin, I guess that's something similar to that. Anyway, the spectrum for that particular drug is E. coli or enterococci. And usually you would use this for urinary tract type infections. So urinary tract only is where it's typically being used. And then acidic urine, better effect treatment and prophylaxis of uncomplicated UTI. So basically, you'd use this, like it says, for either prophylaxis or just like some treatments of UTI. And then along with that, notice we have another mention of G6PD. So once again, they could always give you the picture of somebody with G6PD, say they had a UTI, what drug did they possibly have, right? So just kind of remember all of that together. I left the questions in here just in case you guys, of course, want to look back through those. But anyway, so which does not cause photosensitivity? So the only ones that that does not lead to that is a vanc. And then you kind of see the sun fries down here, and that's on the next picture anyway. But yeah, this tells you like all of the ones that has that photosensitivity. So any tetracyclines, like it mentions doxy back here, that's a tetracycline. Sulfonamides and fluoroquinolones. And notice that it mentions sulfonamide, so sulfamethoxazole, and that fluoroquinolone, some moxie. So with that in mind, vanc would be the answer for that question. But yeah, I would say pretty high yield for sure. I think we might have had at least one question pertaining to this, just the photosensitivity in general. But yeah. Then, which drug should not be used in children due to potential discoloration? So this is talking more about the chelation thing that we've already talked about. So this is basically just asking you which one can cause that. And the only one that we've talked about, like specifically that's mentioned in these answer choices, is fluoroquinolones, because fluoroquinolones can do that. And which ones out of these is fluoroquinolones? Is levofloxacin. But notice down here that that's not the only thing that can cause chelation. You can also have tetracyclines also do that. So if doxycycline was on here instead, that could also be, the answer. But in terms of what we just talked about, levofloxacin. And then I put down here just like a memorizer, just in case like you forgot like which category has what ending and stuff. Which drug has little activity against Pseudomonas? Honestly, don't remember her asking like. I mean, maybe she had a Pseudomonas question, but like we didn't even really talk about carbapenems on here, so I just really don't see her asking something like super similar, and with the answer being ertapenem. But yes, that's the answer for this question. But like I said, we haven't really covered that Pseudomonas stuff in this particular lecture, so it's kind of oddly placed to me. And then, so somebody comes in with so they have COPD, they develop tendon pain after treatment for a community-acquired pneumonia. Was the most likely causative agent? And if you guys remember, right, we had those fluoroquinolones, right, had that adverse effect of tendinitis. So notice, of course, they have that tendon pain, and they were treated with a community-acquired pneumonia. So even without the tendon pain part, even if you just knew the community-acquired pneumonia with what we talked about, it has to pretty much be either levofloxacin or moxifloxacin. So that's how it kind of differentiates in between Cipro and Moxie down here. And of course, that tendon pain gives it right away as being a fluoroquinolone. So that gives you the Cipro and Moxie, and then that CAP or community-acquired pneumonia gives you a way for either Levo or Moxie. In this case, Moxie. But yeah. Now on to pharmacology of antifungals. All right. So this one, I don't think it's very long, honestly, but we'll just get right through it. So drugs to know for now. Like I said, I left these in here just in case you didn't read any of them. But more than likely, of course, the ones that are in red are going to be more high yield. All right, so polyenes. So this is like a specific category. So what they do is they bind to ergosterol and they increase cell permeability by that binding. Definitely the more important portion, I feel like, is just that it binds specifically to ergosterol. And then amphotericin B. So that one's pretty much always known as being really bad because of like the adverse side effects are really bad for that particular drug, and so you hear it being called as amphoterrible sometimes. And also it's so just a little fact that I kind of took from another slide just to add in here to get rid of another slide is that it's cleared renally specifically. It's very broad spectrum, however, even with that like toxic side effects, it does still have a purpose because it's very broad spectrum, and so it can hit all of these things. But more than likely, if she were to ask you, of course, anything specifically out of here, like what it might hit, would be more of these probably top answers instead of this big hunk of things here. Also, so within that category of polyenes, you have nystatin. Um, and with nystatin, you need to be thinking about Candida albicans. Um, and I remember I had actually like a practice question, I think, specifically ask nystatin or Candida. So it does come back for sure. Um, but yeah, so and that's going to be more like a cutaneous mucocutaneous fungal infection caused by Candida for nystatin. And then so just a little bit more about amphotericin. So like I said, it's very very toxic because it leads to that perforation of like the cell membrane because it just keeps poking all those holes in it. Along with that, since it has like that renal toxicity, because it's cleared renally, so therefore if it's toxic there, it's going to be toxic there as well. Toxic here, toxic there, right? So along with that, you kind of get that renal toxicity because it gets cleared that way. And so with that in mind, you need to kind of give extra hydration or adequate hydration in order to kind of keep back that toxicity. And along with that, since you're giving the hydration anyway, you need to monitor serum electrolytes and creatinine pre-treatment and at least weekly after giving amphotericin B. But yeah, so very important. And I put the 2 stars here because I'm pretty sure we had a question about like an amphotericin B like side effect type deal, like kind of like what we would give, maybe like adequate hydration with that or something like that. But so that's why I have the stars on this slide particularly. Now on to anti-metabolites. So you have flucytosine. And the thing she highlights here is more so like the mechanism with it. So flucytosine, what it does is it penetrates fungal cells, and then it's converted to fluorouracil. And of course, that uracil should kind of like ring a bell anyway, right? Because that's like one of the things used, like one of the nucleotides, I guess is what, yeah, nucleotide, which is used in like RNA synthesis. So if it's converted to fluorouracil, that fluorouracil is able to kind of like compete with your traditional uracil, and therefore it's able to kind of like mess with the RNA synthesis. And since it messes with RNA synthesis, it could mess with specifically mRNA, right? And if it messes with mRNA, then you're basically messing with protein synthesis, right? Indirectly. So altogether, it kind of just shuts everything down for the fungus. So then resistance-wise, so it can be rapid if you're using it as monotherapy. So more than likely, you wouldn't be using this drug alone. You'd be using it with something else. In terms of adverse effects, so it's going to be more cytotoxic. And along with that, you're going to have bone marrow suppression, anemia, so your RBCs would be lower, neutropenia, and then thrombocytopenia. So that'd be like low neutrophils and low platelets. So what they could possibly give you if they were to ask you a question on this is more so like give you either kind of like an anemia type look to the patient coming in, or they may even mention specifically bone marrow suppression, but more than likely they're going to give you somebody that like it seems like they have like an anemia. They may even give you like platelet levels or things like that too. On this question, if they had a question on this one, and then they might even ask you just to make it second order, like what the mechanism of action for that particular drug is that causes this bone marrow suppression that you would give for somebody that has a fungal infection. So maybe they could ask, indirectly for the mechanism of action for that one. Then on to different drugs once again. So squalene epoxidase inhibitors. So terbinafine is the one that's like the big one in this category that you're gonna have to know. So what it is, it's an oral or it can be cream as well for dermatophytes and onychomycosis. So make sure you know that specifically for these two. So that's why I have it bolded there for you. And also that it can accumulate in the nails, so it kind of like helps it do its job even more efficiently, right? Because it is able to accumulate in that kind of area where you'd have these kinds of infections. And adverse effects wise, it just has hepatotoxicity. Okay, so just make sure you know that it has that adverse effect along with that, that it targets dermatophytes and onychomycosis, and that it can accumulate in the nails. So azoles, so these are pretty common like fungal drugs that you hear a lot about. The main mechanism of action for those is that it inhibits 14-alpha-sterol demethylase. So it's that specific enzyme. And since she has it in red, just be prepared to know that specifically of a mechanism. So notice that in comparison to, let me try to go back to that. So in comparison to polyenes, so amphotericin B and nystatin, right? These bind to ergosterol, right? Azoles, they don't bind to ergosterol, but they actually block the conversion of lanosterol to ergosterol. So they still mess with that whole pathway, but they don't bind specifically to ergosterol. They instead inhibit the enzyme that creates ergosterol. So they're all affecting like the same similar pathway, but they're doing it in a different way. So just make sure you know those specific mechanisms, like I've been saying. Um, and then just like kind of like a little fact along with what 14 alpha sterol demethylase is. So it's a microsomal CYP450 enzyme. Honestly, I don't remember anything really high yield at all about that. Definitely the mechanism is like the bigger deal up here. Adverse effects wise, so you have once again hepatotoxicity with these drugs, and then you also can have decreased testosterone. And it mentions ketoconazole because that's the one like that's more mentioned when you mention decreased testosterone. They just kind of tend to go together more often than just any other traditional azole. You'll learn more about that whole pathway and all that later down the road. Anyway, you'll hear once again the ketoconazole thing. Um, but yeah, I have it underlined here because I mean it's possible that she could ask you a question on that because it's just important in general to know. In fact, I'm gonna plug this thing up. I just now noticed I was like, why my screen? That's why. But anyway, so azoles. So these are like systemic azoles. Um, Fluconazole. So not ketoconazole, right? Fluconazole is used orally for treatment and prevention of vaginal candidiasis. So remember, we already kind of mentioned um, candida before, but this is specifically for vaginal candidiasis. So that one didn't mention anything specifically for vaginal, but it mentioned candida in general. So nystatin's the other one that we mentioned with candida. So it might be a good idea to just kind of like put those two together, but be sure to realize that fluconazole is with vaginal candidiasis. Now, it may inhibit some CYP450, and there's also a risk of hepatotoxicity, even though it's renally clear. Um, and then, so in terms of like use wise, you do not use them for aspergillus, fusari, or zygomycetes, such as mucor. But yeah, definitely just know that you typically would use this with vaginal candidiasis. Itraconazole. So I put a star here for that one just because I felt like it seems to me like it was important to kind of know that it could be exacerbated with CHF. Um, and so there's like also a box warning, and that's because of this box warning with the negative ionotropic effect. Um, Now, also important that she hasn't read for you is that it can treat aspergillus and blastomycosis. And notice on this last one, right, fluconazole does not treat for aspergillus. So if they found out, so say the question stem says, they had some kind of infection, more than likely it'd be like a pulmonary infection of some sort, and it says they identified as aspergillus, then you would want to say itraconazole is the one you do for that. So just kind of always look at what makes it different from another drug in that particular category. She could also, kind of ask a question based on that sort of thinking. Then voriconazole. It's a lot of azoles. So voriconazole. So notice it covers both. It's kind of like almost like a mix of both in a way of itraconazole and fluconazole because it can cover aspergillus and candida, including a specific like type of candida. So I had that underlined, but I doubt that's really all that important to know. Infusarium. So it covers those specifically, but not zygomycosis. Then ketoconazole. So we already mentioned like the important thing to know with the ketoconazole. And since she mentions it already twice anyway, it seems like maybe she did have a question on that. But I know you definitely have a question at some point about it. But I put 2 stars on there because it's just definitely important to know with the ketoconazole. Um, and the reason that it kind of has an effect is because it has that effect down um, with, well, I don't know why I said that, but anyway, it's used in prostate cancer to reduce testosterone levels, um, in hyperadrenal states, such as Cushing's, to reduce adrenal steroids, and so therefore it can be known as a corticosteroid suppressor. Um, the thing to really also remember with ketoconazole is the gynecomastia, and you kind of relate that with the decreased testosterone levels. It's just kind of an easier way to think about it. So think about ketoconazole, think about fungal infections, and say after it, this would be more than likely like a type question where they would give you somebody that they come back in after they've been treated with a fungal condition, like say they've been treated by that, and then they developed gynecomastia. Okay, so that's kind of the kind of question that would come from the answer being ketoconazole. But of course, they wouldn't say gynecomastia. They could say like extra tissue or something like that. So just be on the lookout for that. Topical azole. So this is like a little bit different than the ones we've been talking about because those other ones we've been talking about are all systemic. These are more, of course, going to be probably a little bit less systemic, more localized because it's topical. Then you got clotrimazole and miconazole. Um, I had that underlined. Don't really pay attention to that. I just thought it might have been important at the time, but just know that these two are going to be more topical azoles. That's really all you need to know from this particular slide. Then echinocandins. So these all end in fungin. So that's why she had this particular part of the words put in fungin here. Um, and along with that, they're used for candida. And notice she puts including azole resistant. So in the question stem, she would have to have said either they've had an azole before and it didn't work. So this would be more like kind of like a second line treatment for candida. Also, probably, I don't think she would really ask you a question on aspergillosis with this one. I mean, maybe she would, but of course, if she did, she wouldn't have a chemokine, like she wouldn't have a drug that ends in fungin and give you one of those other drugs that cover aspergillus as well. Um, so that's just something else to know. In terms of adverse effects, you can have hepatic effects, but they're apparently rare. Then you have griseofulvin. Now this one, like I remember this being involved with the same sort of deal as metronidazole, so that disulfiram reaction is definitely important to know. Also, knowing the mechanism as she has in red here, so it binds to tubulin, and it kind of like almost in a way gives away its mechanism, that like what tubulin is. And so once it binds to tubulin, it inhibits the function of that mitotic spindle. And so what that would do is basically lead to a lot less division, basically. So it's kind of like pretty far in that process. So it's inhibiting function of that mitotic spindle. So therefore you won't have cell division, and therefore they'll die out over time. Also binds to keratin, so it can also accumulate in the skin and the nails, like we talked about with it. It's back a few slides ago. Let me go back to that. This one. So terbinafine. So it mentions that specifically as well, but more than likely, I don't think she could really fashion a question out of that point specifically. But it's just something else to know with griseofulvin. Once again, like I mentioned already, it can have that adverse effects or adverse reaction with ethanol, just like metronidazole, because it leads to that disulfiram reaction. Now here is that slide with the disulfiram reaction. Now, is she going to ask you like specific details on kind of like, I guess, the innards and the ins and outs of the disulfiram reaction? Probably not, but she'll give you a patient that comes in with a like something similar to this disulfiram reaction. And so what they could come in with is typically you see like flushing, severe headache, sweating, you see all this kind of deal, right? So they'll come in with those symptoms, okay, and then they'll say, kind of what drug did you give them? And then they'll say along the lines of like they were treated for some sort of condition, like back, maybe a week ago or not so long ago, and then they, ingested alcohol, and they come in with these symptoms. Then you need to be thinking, okay, disulfiram reaction, right? And then if you know what the disulfiram reaction looks like, then it's got to be either metronidazole or griseofulvin of the ones we've talked about so far, right? And so, of course, that the only thing that would, of course, differentiate you at that point would be what they came in with originally. Say they came in with a fungal infection, so then you want to be thinking griseofulvin is the drug that would, caused that. But if they came in with whatever you treat, the metronidazole with, then you need to be thinking metronidazole. So that's once again kind of like the logic that you need to kind of have to be prepared to use on the exam. So that's why I left this slide in here because it's a nice reminder of what the disulfram reaction looks like, and it gives you also just a general like what that process looks like. So with this top paragraph here. Also, so we'll go on to these questions. I already have like the answers and everything down there. Anyway, which antifungal causes renal toxicity, including azotemia, hypomagnesia, and hypokalemia? The one, the, honestly, if I had to give like a cold guess, anyway, and I like have no idea at all, I would say amphotericin B anyway, because I mean, like, look at all these different things going on, and as you know, it's info terrible, right? But you do remember, she did draw a lot of attention to the renal toxicity with amphotericin B. So, with that in mind, because it has that renal toxicity, and she didn't really have this other stuff in red, but if you knew the renal toxicity and you knew a whole bunch of other crazy stuff going on, I would kind of lean toward amphotericin B anyway. And with that in mind, make sure you remember the fact that you would give fluids with that, and also that you would give electrolytes as well, to kind of like balance out that fluid intake. All right, now on to pharmacology of this stuff. Drugs to know for now. So we've already mentioned at least a couple of these, but she does mention definitely a bunch of other new ones. So we'll just get right into it. So tuberculosis. So the only thing really honestly important on this slide is that it's not monotherapy. So you know how we talked about earlier with ripe, you can actually even see it up here in the chat still. You don't just give rifampin, okay? You just don't just give rifampin. You'd have to give like rifampin, isoniazid, like a bunch of other drugs along with that. All right, so now I left this slide in here just to kind of give you a reminder of rifampin, like the more important things with it. Once again, notice in red here that rifampin, the red-orange bodily fluids, more than likely it'd be a urine question. And then it's a powerful enzyme inducer as well. But yeah, so I just left that in here just to kind of give a reminder. And isoniazid, so this one's used only for TB. And it also goes through that anoscillation that we talked a little bit about earlier with that Steven Johnson syndrome problem with the sulfonamides. But of course, that's totally unrelated in terms of drug class to these. But it has that anoscillation step as well. And so INH adverse effects, so that would be the isoniazid. So that's what that's short for. You have hepatitis you can have with that. And the thing that I felt like was probably a little bit more important to know here would be the peripheral neuropathy. So it could definitely describe some sort of numbness, maybe an ataxia even, but more likely like a numbness because she, highlights peripheral neuropathy. But the thing to note with that is that you prevent with pyridoxine or vitamin B6 supplementation. So she might give you a question about like somebody comes in with TB, right? And then they have this peripheral neuropathy. So say they have loss of sensation and probably like an extremity more than like, some sort of extremity loss of sensation. Okay. And so then you need to think, well, okay, what drugs do I use for TB? So then you think ripe, okay? So rifampin, isoniazid, all of them, right? And then you come along with that, and it's like, okay, well, they have peripheral neuropathy. What drug could be causing that? Well, then isoniazid, would be the thing you need to think about. Could also even ask, like, even further step, could be like, okay, well, maybe not ask the drug, but what would you give to prevent that peripheral neuropathy? So then you need to think about vitamin B6. So it's possible that you would ask that, but I just thought it was a very important point to know. Also, it can lead to a rare lupus-like syndrome. It does this by an increase in slow accelerators. Um, and because lupus, those people would have that slow acetylation could lead to that toxicity effect and then lead to this lupus-like syndrome. All right, so TB treatment. So this mentions the other drugs that we haven't really got to of ripe. Also streptomycin it mentions. So pyrazinamide is the P in ripe, and then ethambutol would be the E in ripe. So, and I even put down here just to kind of remind you, think ripe boards wise for sure. And honestly, here it helps you out anyway, so might as well just remember it now. At the time, I didn't really know about ripe, so I put SPE. I thought that was being crafty. So maybe that helped you out too. I don't know. But so streptomycin, it mentions that as well. So make sure not to forget about that one. All right. So just a random slide about macrolides. So you got azithromycin, clarithromycin, and erythromycin. Um, so I just left this slide in here because honestly, does it have like a specifics for TB? I just feel like it came out of nowhere. But anyway, it's obviously still important to know. So it's bacteriostatic. Um, and it binds to the 50S subunit. That would definitely be something you would need to know for macrolides specifically. Um, there are other drugs that do 50S subunit, but macrolides are one of those categories of drugs. But yeah, all the other stuff, I don't really remember it being as important. Definitely knowing the mechanism of action, the drugs in red, and bacteriostatic, I doubt that would be important either. Adverse effects. The adverse effects are always important in terms of her exams. So make sure you know definitely the ototoxicity, hepatotoxic. Those are probably the seems to me like the bigger one. Maybe that and the profound diarrhea, cramping up there as well. Metallic taste with clarithromycin, and you can have prolonged QT as well with erythromycin, clarithromycin. All right, now on to folate antagonists. So we've already talked about this slide anyway, so I'm not going to cover it really. But yeah. Then metronidazole, we've once again already talked about, but I do like this slide a little bit better because it kind of like skips by a lot of the extra stuff that you didn't really need to know as much. It kind of gives you like the bare bottom details you need to know. So with that in mind, used in treatment of extraluminar amoebiasis, used in Giardia, and used in Trick. And of course, along with that, remember the disulfram reaction. Okay, so this is all just a reminder. And she had it in here anyway, I guess, just to kind of review it with you once more. But yeah, make sure you know all of that for sure about Metro. And then I don't remember if this was like particularly important, but she had this in red. But P. falciparum, so this is going to be like one of those bacteria associated with malaria. It's typically like one of the worst ones to get, so it's responsible for the majority of serious complications, and death and drug resistance is a serious problem with falciparum specifically, is what she's talking about. She does mention like drugs that are specific to the different types of bacteria, so that's where you sort of get like those test questions coming from. Also, we'll go into like what kind of person would want what type of drug. That is also important to know on these, and I'll mention it as we go along. So primaquine, what its specific thing does is it can interact with P. vivax and P. ovale. Okay, so make sure you know that it's specifically those two types. So P. vivax and P. ovale. Okay, prevents relapses of those malarias. Standard chemoprophylaxis doesn't prevent release because hypnozoite forms are not eradicated by those agents. Basically, the more important thing to know, like I said, is the Vivax and Ovale in terms of the exam. It can also reach peak plasma volumes within 1 to 2 hours. Side effects typically, and as you can see, another G6PD person, tends to always be a question in some form, shape, or manner. So it definitely doesn't hurt to keep that in the back of your mind. All right, primaquine. So now we're going to get on to more the kind of people you would give this drug to. So we'll kind of go into that. So it's most effective medicine for preventing P. vivax. So we already mentioned P. vivax anyway, and no valley, but I guess it's specifically a little bit more stronger against vivax. And so if it gives you a question, more than likely, with the person having P. vivax, then you need to be thinking about primaquine. Um, Now, it's also more important is this good for last minute travelers because the drug is started 1 to 2 days before traveling to an area where malaria transmission occurs. So, what the kind of question it would look like if, and she does like, I think there was at least one or two questions pertaining to like which of the malaria drugs you would give, typically just based on if it's like a short trip, like is it last minute traveling or like how long do they need it, things like that. So she does have that in red, and there at least was one, maybe two questions on that particular concept with these drugs. So with that in mind, I'll go back through it again. It's good for last minute travelers. Okay. And then it cannot be used in patients with G6PD deficiency. We've already talked about that, so you already know that. The reason I have the 2 stars here specifically is because of that last minute traveler statement and also with the buybacks. And GCP. Honestly, all of it's high yield anyway. Then you have chloroquine. So notice that this is kind of, it has the more important point on this slide in red. Its resistance is very common in P. falciparum. So remember that P. falciparum is the one that typically gets that resistance towards these drugs. But apparently chloroquine is definitely more susceptible to this sort of thing. So I figured that was important, so I put a star with it. And then notice here it says some people would rather take medicine weekly. So this is going to be more the person that doesn't want to like continuously take medication. They want to take like maybe once a week, right? Then you need to be thinking about possibly giving them chloroquine. The reasons that you might avoid using this drug is it can't be used in areas, of course, with chloroquine or even mefloquine resistance. And also that it may exacerbate psoriasis. So if you had somebody that came in with, dry skin patches or whatever, then you obviously don't want to give them chloroquine because that could mean that they have psoriasis and therefore you don't want to give them something that's going to make it worse. All right. Then you have atovaquone and proguanil. So these are active against tissue and erythrocytic schizots, allowing chemoprophylaxis to be stopped 1 week after the end of exposure. So these are basically what this means is that it's like allowed to basically end it short instead of having to continuously use this drug for a while after you've had exposure, like a lot of those other drugs will do. And once again, notice it says it's good for last minute travelers. So make sure that you kind of group those ones in a kind of like a little category in your mind. Like, okay, last minute travelers, think about this one and think about the other one that was last minute traveler, right? And then good choice for shorter trips. So not only is it good for the last minute traveler, but it also be for like shorter trips because you only have to take the medicine for 7 days after rather than 4 weeks. I mean, 4 weeks, that's crazy. Anyway, when you think about it, and you're taking a drug that you're no longer even having the exposure to for a month after you're done with it. But more than likely, if she was going to ask you probably to differentiate between, using that drug, the other last minute traveler's drug, or this one, she would probably instead give you like, this person is only going to, be there for a very short time. So then you want to be thinking more toward this atovaquone, proguanil combo for that. So that's why I have the stars besides that point. Then mefloquine. So that's going to be is used for that multi-drug resistant forms of P. falciparum. So if you notice, the only one that we've talked about so far that's like actually effective toward falciparum is mefloquine. So this one. So just kind of keep that in your mind. Half life is about 20 days. And so, with that in mind, you have weekly dosing and steady state is achieved over a number of weeks. So, it takes a while in order to have, like that effect that you need for that protection against, the malaria infections. Adverse effects. So it's got box warning of neurologic and psychiatric toxicities. So possibly they could have somebody that came back from some sort of missionary in Africa or something like that, and then they have these neurologic and psychiatric toxicities. What drug did they take, or something like that, right? Of course, they wouldn't say neurologic and psychiatric toxicities. They would just give you symptoms that are associated with that, and you'd have to come up in your mind and say, okay, methylquin. All right, so these are going to be more good choices for long trips because it's taken only weekly. So this is the only one so far that we've talked about with long trips. So put the stars there for that. It's not a good choice for last minute travelers because they have to be started at least 2 weeks prior to travel. And for trips of short duration is not good because you'd have to take that medication for 4 weeks after travel. So it's like the opposite of that one we just talked about, basically, in terms of that. And then you have quinine. So quinine is gameticidal against P. vivax and ovale. So that kind of reminds me of like that first one we talked about. And it's not really effective against P. falciparum. This is going to be more probably along the lines of if she did ask you a question with quinine as the answer. Probably going to be more an adverse effects type question. So you'd have to know like the adverse effects of that drug, and then you'd have to be like, okay, well, what drug was that she gave for quinine, based upon the adverse effects that the stem gives you. So it's got tinnitus, headache, nausea, all these other things with it. Then you got pyrimethamine. So it's not widely used for chemoprophylaxis because of frequent resistance and toxicity. So it's just not really used very often, basically. Antibiotics. So you can also use doxycycline, but it's going to be more used in areas with high rates of resistance to other antimalarials. And I think we may have had a question pertaining to doxy usage, but I could be wrong. But basically, it was just kind of saying like you're in an area um, where there's like lots of resistance. Also, it's good for last minute travelers once again. So doxycycline is another kind of drug that you need to map in there with those other ones. Other antiprotozoal drugs. So you got natoxinide. So this is the one that you would use for Giardia and Critosporidium parvum. That's going to be more like a HIV associated infection, Critosporidium parvum, and then Giardia. So just make sure you know natoxinide for Giardia and Critosporidium parvum. All right, so this gives you like a question here. It gives you a male student traveling to Honduras and over spring break, and they leave in 4 days. So notice this is like almost like a last minute traveler person, right off the bat. History is significant for anxiety and depression and allergy to sulfa drug. Okay, so you can't give pyrimethamine, obviously. And then where he experienced yellowing of the skin and eyes, a dark urine, fatigue, and shortness of breath. The primary malarial species is P. vivax. Was the most appropriate prophylaxis to give? So the answer in this case would be C. And the reason that is because I actually have like them all listed down here. So chloroquine, right? It's actually one of those drugs that must be taken quite a bit of time before and after travel. So it's not going to be the kind of drug that you would give for somebody that is doing like a last minute trip. Primaquine, okay, you were thinking maybe that one, but it can't be taken in people with G6P deficiency. And where you get that G6PD deficiency from is you actually get it from this yellowing of the skin and eyes, the dark urine, fatigue, and shortness of breath. So that's where you kind of get that along with that. So that's where that kind of comes in terms of the stem. The mefloquine, it can't be used because it's got a history, because they have a history of those neuropsychiatric disorders, right? So it mentions that anxiety and depression. So it's kind of like making sure you get every piece of the puzzle before you give, you know, your last final answer, basically. That's kind of how a lot of those question stems will be. So make sure you just kind of know all those other little intricacies along with, the if it's a last minute traveler or whatnot. Review. So this gives you a G6PD deficiency review. I kept that in here and I put the star there because it comes up a lot. um, Even practice board questions, it comes up a lot. So it's always nice to get a review of G6PD. Um, but yeah, and that it kind of helps you along with that practice question. So I just left it in there. All right, so now anti-helminthics and anti-ectoparasites. So drugs no for now and later. I just left that in here as always. All right, so then I left this slide in here because I mean it's a recycled slide anyway, um, but it just kind of gives you like because we're going to be talking about drugs that are used for nematodes, and so this gives you like a slide that, and she has them in red here, of like say they found this particular nematode in somebody, like what drug would you give them, type deal. So now on to the drugs that you'd give. So you got albendazole and mebendazole. So those are the two that you kind of need to associate more along lines with nematodes. Um, I don't remember there being like questions on any of this other stuff on this slide specifically, but yeah. So just make sure you know that albendazole and mebendazole nematodes basically. Then you have DEC or diethylcarbamazine. These are going to be used more for filariasis. So that's a very specific type of infection, um, and that's kind of like named based off of like the disease process of that particular infection. So make sure you know that it's used for filariasis, however you say that. And then side effects, they're limited and just dependent upon the number of microfilaria in the blood. And it can only be obtained from the CDC. So more than likely, you probably won't ever prescribe it anyway, but it's definitely important to know that it's with filariasis, and that it's dependent upon the number of microfilaria in terms of side effects. Then ivermectin. So ivermectin, it induces a tonic paralysis of musculature. So that's something that it does. It has a very broad spectrum when it comes to roundworms, and it lists off like all these different roundworms specifically. So they could give you like a question where they mention, that they have a strongyloid or an onchocerciasis or something like that, right? They could give you any of these, and then roundworm infection, and then be like, okay, well, what kind of drug would you give with that ivermectin? It's well tolerated, but however, there is a Mazzati-like reaction in filarial infection. Okay, and so where you see that, and you notice actually it mentions it right here, so it also can treat that. But the problem with using ivermectin is you get that Mazzati-like reaction. So more than likely, this would be one of those questions once again where it describes a Mazzati-like reaction and that they had filariasis. Like which drug did you give them? Kind of deal. And then just kind of like just to go back and remind you, DEC is the other one that is associated with that particular infection. And then on to this Mazzati-like reaction. So what it looks like is, I mean, I underline like the more common symptoms that you kind of see with this Mazzati-like reaction. So you'd see mild itching, swollen, tender lymph nodes that last a few days, and that are relieved by aspirin and antihistamines. Okay, so you see somebody that you see the question stem, they have this type of look to them. Okay, and that asks you, well, what drug did you give them? Then you need to be thinking more than likely ivermectin because diethylcarbamazine, of course, that you can only get from the CDC. All right. Then pyrantyl pomoate. So these, honestly, in a way, it's like you see the pinworms, so that might kind of help you since it's got two P's there. Maybe you can kind of like overlay that. It's effective for pinworms, ascariasis, and hookworms. So we haven't really talked about any of those infections in particular yet. So make sure that you know it's for specifically pinworms, ascariasis, and hookworms. Praziquantel. So this is going to be now the first line it gives you in red is going to be like its mechanism of action. So it gives you an increased permeability of cell membranes to calcium. So that kind of leads you, of course, if you think about it, more calcium within the cells, well, that's going to lead to more muscular activity, and therefore it kind of like um, prevents, I guess, further infection in a way. So it's approved for schistosomiasis and liver fluke infections, but it has activity against what she has in red here, so trematodes and cystodes. So that's the first time that she's mentioned trematodes and cystodes. So if they have a tapeworm or they have a trematode, you need to be thinking about praziquantel. Then ectoparasites, I left this slide here just to kind of like give you an understanding of what she meant by ectoparasites because I felt like if I just left the last slide in there, it wouldn't make any sense. So I made sure to leave this as well. But yeah. And then so the two drugs she has for these is permethrin and lindane. Um, the only one that I feel like she would be more likely to ask would be lindane, and that would be because she gives you that limit use concept here. So it has an increased potential for neurotoxicity in children, in adults less than 110 pounds, and in patients with underlying skin disorders. So maybe the question is more like she could give you a question that I've been kind of talking about. Somebody comes in with those effects and they ask you what drug it was. Or it could be the fact that maybe this child has some sort of brain condition or something like that, that puts them at more risk if they were to develop a neurotoxicity. Um, Maybe an adult less than 110 pounds, or maybe a patient with underlying skin disorder. You don't want to give them lindane, so therefore you default to permethrin. So that's another question that you could get from this slide. But honestly, I think that about covers us on this. So what I'm going to do is I'm going to post the attendance thing in here again for everybody to sign that, just in case you haven't. Um, yeah, I think that covers us. So I'm gonna put also my phone number in the chat. So if anybody wants to ever just ask me any questions that way, you're free to. Um, if you have any questions pertaining to like honestly anything, like what kind of questions they like to ask, or was this particular point important? Yeah, Stacy, she also posted her study guide on Facebook as well, according to her. So you can also take a gander at that. Um, but yeah, so I think that's about it for us. Yeah, no problem. Um, like I said, I appreciate you guys coming out for that. Do you have any suggestions for physio in general and the TBL? Stacy, you honestly, she probably has a better answer for that. She's actually a physio tutor. But in terms of what is the TBL about? Is it just endo? Just endo, I guess, right? Or does it have a particular subject? Infertility. Okay. Um, I know there was definitely like an importance with like knowing hormones, of course. Well, it's endo, but like knowing which ones are higher at what stage. Like based upon what day it is and stuff like that. That's always important to know with those. I mean, I guess it's possible that um, honestly, I don't. Stacy, you think you can give maybe a better answer than I'm giving? Sorry. Um, but yeah, in general, physio wise, I can help you with that anyway. So in general, the things that are like that I've been telling people that's like ask me, um, I remember there being a lot of like kind of questions where you definitely need to know the pathways for all these, for all the hormones, right? So like GH, HDH, all of them. Okay, you need to know like if this particular hormone goes up, does this particular what does this one do, basically? So the pathways are super important for endo. Also, what's important to know is to be able to differentiate between like whether it's a primary condition or a secondary condition of some sort. So a lot of those, I think it was like type some kind of Bones disease. I think it was Bones disease or something like that. Like there's like a few of them that you'd have to definitely know like the difference. Oh, like Cushing's disease, for instance, right? There's a Cushing's disease and there's a Cushing syndrome, but they're based upon what level of dysfunction you have, whether it's at the pituitary or if it's at the actual adrenals themselves. So it just depends on that. So that's also important to know. In terms of pregnancy hormones, I know there was questions on like I know we had to know like thecal cells and granulosa cells and like what what cell type has what specific receptor type. I remember that was a question I think. Um, but yeah, that sort of thing's important. I think that covers most of what I can honestly remember right off the bat. But Stacy's still here actually. I don't want to like not give her. Ah, okay, she's not here. All right, so let me honestly, I'll scour just for a second, see if I can find anything that I use for that. Um, if I do find something, that leads me down that rabbit hole, I'll do that. But I doubt I have anything pertaining to particularly to the TBL, but I'll look into it. If not, if I can't find anything, Stacy, so you know how that drive I gave you guys? We actually use the same drive anyway, so that all them guides drive. That actually has her material there as well. So you could also, take a look at that for maybe more like the high yield stuff, because I'm sure she has it highlighted on there. So I hate to like, give you only what I kind of remember. But yeah, I'm sure she has it highlighted there for you guys there as well. Let me see. And physio, same 6. Jeez, that's a lot. Case report. I don't even know what that is. Physio endo notes. What is that? Oh goodness, no. Oh, okay. I remember what this is. So Palazzolo actually used to teach endocrine, and a lot of people used his stuff to kind of like supplement some of the stuff because it was like hard for them to understand it. So I can send you that if you guys don't have that. Have that. Um, but yeah, I know some people kind of use that as like a reference, but of course, it's a different teacher altogether. So I think he taught it like the year before Gibson got here. Um, but yeah, hold on a second. Let me pause share for a sec, just in case it's something that like gives away answers and I have no idea. Let's see. It looks like he give you guys a article? Is that what he did to prepare for this? Like, what did he tell you guys? I see an article that I had. There was an article. Okay. Did he say anything about like knowing lecture stuff, or just particularly the article? Both. Okay. More than likely, I would say most of his questions are going to come from that article. Actually, I do kind of remember it now when I look at this thing. Let me see here. I think let me just give like a small little glance at it, and I'll give you guys my kind of opinion on what, because it is kind of coming back to me now when I look at it. Okay. Let's see here. But yeah, I remember a lot of the material coming from the article. A lot of it, at least for the TBL. Um, and then there was like I think there was questions pertaining to like when you would give a particular contraception over another one. I know there was at least 2 or 3 questions it seemed like to me on that TBL on that. Because I remember I was like having a fight with my TBO group because we were like, I don't know. Do you know? I don't know. Do you know? That type of deal. And then I think there was like questions asking about maybe like risk factors for certain types. Maybe like if you give folic acid or iron for that particular drug or whatnot. I remember that was something. There was like there's questions kind of like that, or what were asked on that TBO. It was more like which type would you give? Like why would you not give this type? Um, what should you supplement with that particular um, contraception. Um, and then I remember there was like some kind of like annoying question that like everyone thought it was like something different, but I think it was like it ended up being like one of those artificial insertion type contraceptions. I think that was like the answer to that question was like maybe the ring or something, like how you can insert those rings. I think that was like one of the answer choices for one of them, but like everybody was like, "What?" So maybe that's just a little bit of a heads up. But in terms of specifics, unfortunately, I can't remember, like right off the top of my head. But the things, like I said, that I remember looking at this article a lot, not only like for those answers, you know, but also for the activity and stuff. So from what I remember, I think a lot of them come from the article. But I hate to lead you astray and say none of them come from the other material, but I really don't remember there being, in my mind, from that other stuff. Does that help? Sorry, I try to give you guys a little bit of pointers, but okay, yeah. I mean, I had stuff highlighted, but I think this was beforehand. Was a lot of the article on the test too? Honestly, I would say no. Um, I think there was a few. I think there was a few questions on there, and those are the questions, of course, that I was like, huh. It's like this article, man. Um, but I don't think there was a lot on the exam. I think a lot of the exam was the kind of stuff I already mentioned to you guys. So, I mean, I can resume share. It doesn't really matter. But anyway, I think most of the exam, like I said, was kind of the stuff I already mentioned. I felt like there was like maybe questions pertaining to like whether a particular receptor was like a GS receptor or like a G alpha, like a G alpha S, or if it was like a GQ receptor type deal. I think there was like a few of those, maybe. I think he covered that last. Did he cover that sort of thing this year? Like whether some of them were like G alpha S and G alpha Q and stuff. I mean GQ. Okay, yeah. I know he had a question or two pertaining to that on the exam, because I remember that when I was having to sit there for a second. Honestly, the easiest way to memorize that is just which ones are GQ, because most of them are G alpha S. So that's just a little heads up. Because I know it's like the one I always got confused was like if it's GHRH or if it's GNRH. Because I'm like, why do they have to make them so close to looking? So close looking. But yeah, I remember I got that question right just because I remembered the GQ, and I was like, okay, well it's a GS or whatever. Remember there was a question on that, and I know there was a question with like I was saying earlier with the theca cells and the granulosa cell type jazz. I know there was a question on that because it was asking like when, because I hate to like really try to like look dumb or something, try to remember. Um, I think it was that cell. I think it's the theca cells. Maybe is it theca cells or granulosa cells that like they get that other receptor at a certain point. One of those change. Like which one is that? Anybody remember? I say because I think it was like they only have an FSH, but then they get an LH receptor. Is that right? There's a cell type for that. Yeah, I think it's granulosa. I'm pretty sure. He mentions it in his lecture, um, but I think there was a question pertaining to that because I thought it was kind of like off the wall, so that's why I memorized it and just happened to get it right. Yeah, so like I think it's a certain point within I think it's like after ovulation maybe, and like they turn into those theca interna, theca externa type jazz. It's when that happens, I think. Yeah, yeah, pre-selection. That's what it is. Yeah, pre-selection for FSH and post-selection, yeah, FSH and LH. Yeah, yeah. There was a question on that because I was kind of confused on it, when I got the question, but then I'm like, oh, he's talking about that. So I remember I got it right, but it's just, I think it was asking like maybe which cell type did that. I think it was maybe the question for that. Um, but yeah, a lot of the questions that you're gonna get are just understanding the pathways. That's by far the, I feel like, the big picture. Like the big thing that's important for that. Um, Anybody else have any like specific questions? Like I hate to like not give you everything that I can remember, but if I had all the stuff in front of me, I could remember it. But I don't want to pull up all my PowerPoints to try to remember it. But yeah, like I said, I'm sure Stacy probably she probably has the more higher yield stuff covered in her PowerPoints. I was helping her out the first 4 blocks, but since this whole like coronavirus thing happened, I haven't seen that material, in a while. So I hate to leave you guys, like down a pathway that I just don't know as much about. But actually, I can